بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to welcome you here in this scientific event where we are going to be together to witness another paradigm of our interest as a primary care physicians, family physicians, and those who are engaged in managing pregnant ladies. And in fact, this goes right with the total healthcare transformations that we are encountering today, where we are moving from intervention to prevention, from disease to health, from illness to wellness, and we are trying to reinforce the concept of preventive medicine. And the best tool that we have to fulfill this kind of requirements and to safeguard our community is to implement the vaccinations across the spectrum of ages and spectrum of specific groups. And today we are going to shed a light on a specific groups, which is the maternal groups. So we are going to talk about the Tdap maternal immunization, reviewing the current evidence and recommendations. And for that, we have been privileged to have three eminent speakers today. We have Dr. Muhammad Samanoudi, we have Dr. Reem Al-Inazi, and we are going to have Dr. Amira Ilahi. So with different varieties of topics, we are going to cover the most important part, which is related to the updates in the Tdap vaccination during pregnancies. And then we are going to have the maternal vaccination current status and opportunities. And then finally, we are going to have counseling pregnant lady for vaccinations. So with this, we will have the theoretical part, and we will have another part which will be quite interesting for us to change or to encounter or to overcome the challenge that we encounter in counseling a pregnant lady who doesn't believe in these vaccinations. So I would like to introduce our first speaker. Dr. Reem Al-Inazi. Dr. Reem, she's a consultant OBGYN and Deputy Chairman of Women Health Center in IMC Jeddah. She's a consultant OBGYN Minimal Invasive Gynecology Surgery, Deputy Chairman of the Women Health Center at the International Medical Center in Jeddah, Assistant Professor of King Abdulaziz University College of Medicine up to 2020, and Head of MIGS Unit in OBGYN Department at King Saud University Medical City. In fact, she has a lot of posts, a lot of contributions. She's a speaker in many conferences, and she's a member of a board of review of organization of the Saudi Board Review at IMC. She has a lot of contributions in the scientific events, and she's going to shed a light on the maternal vaccination current status and opportunity. So, Dr. Reem, the floor is yours.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. First of all, before I start, I would like to thank Saudi Society of Family Medicine, Family and Community Medicine for the invitation. Special thanks to GSK and thanks for the great organization. Before I start talking about my topic regarding the maternal status and how can and what is the challenging to implement such vaccine among pregnant women, as all of us know that each country have a national immunization schedule for children and adults. Usually for children, start from at the day of the birth until the age of 18. For the adult, start from the age of 18 or 19 and further. But I don't know if you are aware about that maternal vaccination during pregnancy has been a part of the national immunization schedule. And we have and we need to implement such vaccination among our women. We have to increase the education about this vaccine. So before I start, let us talk generally about the vaccination in women. So women should be vaccinated against preventable disease in their environment prior to conception according to the recommendation adult immunization schedule. Vaccination during pregnancy is warranted, especially if the woman has a high exposure to specific disease, if the infection poses the risk to the mother and to the fetus, and the vaccine is unlikely to cause harm. When the immunization is performed during the pregnancy, the benefit to both woman and fetus should be outweigh the risk of the vaccine itself. There is no evidence of harm of the pregnant woman if she received any vaccine that it contained killed virus or bacteria or inactivated virus or bacteria, toxoid or immunoglobulin preparation. Live vaccination should always be avoided during pregnancy. So this is the adult immunization schedule recommended by the CDC in US. Last update was in 2023. And as we can see here, that the maternal or the pregnant, the vaccine of the Tdap has been a part of the vaccine schedule during a pregnancy. And they advise to give the vaccine for the pregnant woman in each pregnancy. This is the immunization, this is the maternal immunization in general, or the women immunization in general, that it has to be given before, during, or after pregnancy. As I mentioned before, it's better for the woman to receive the immunization before pregnancy, especially those which cannot be given during pregnancy, to prevent a lot of diseases and complications during the pregnancy, which may affect the fetus itself. So if we can look at the vaccination that can be given during pregnancy, they mentioned that the Tdap is one of the important vaccination in addition to other immunizations such as influenza, which is the seasonal influenza. So this is the FDA. They released this last recommendation. It was released in September 2023, talking about the importance of the investigation among women, especially those who are planning to get pregnant, and they advise for many vaccination to be received before pregnancy, and they mentioned the duration between the vaccine and the planning pregnancy based on the type of the vaccine that the patient is, the woman is receiving, and what is the vaccine that it need to be given during pregnancy, and even after delivery, they advise to give some of the important vaccination, which including the Tdap, if it is not delivered during pregnancy. They advise to give the influenza vaccine, they advise to give the MMR vaccine, and the human papilloma virus vaccine. Healthy pregnant ladies can mount similar amount of immunization or respond similar to the non-pregnant patient. What is the benefit of that? And what is the benefit of vaccination, of vaccinating the women during the pregnancy? As everyone know that the placenta can pass the antibodies from the mother to the fetus, and the number or the amount of the antibodies usually depend on the maternal concentration, the type of the antibodies that goes to the fetus, and the gestational age. Fetal immunoglobulin, usually the concentration of the immunoglobulin increase at the first part of the pregnancy, the immunoglobulin usually of the fetus will be less than the maternal concentration increase up to 50% between the gestational age of 28 and 32, and it will be equally at the 36 week, exceeding the maternal level at term. So this shows the value of maternal immunization during pregnancy. So if you look at this figure, it just explains for us what is the amount of immunity that can be received to or can be delivered to the fetus and after delivery by the neonate. So if the patient has, or the pregnant woman has no investigation, the normal process usually that the maternal immunoglobulin transfer from the pregnant woman to the fetus in a specific amount, and combined with the low immunity of the low or immaturity of the immune system of the neonate and inability to receive the neonate specific or the primary vaccination, which usually it will be started after 2 months of the delivery, we have a period between the birth and the 2 months which will not be covered by any immunity or low immunity of the neonate. So we need to increase this immunity. How can we do it? By giving the vaccination. As we can see here, this is the period between the 2 months that start the infant to develop the immunity after receiving the primary vaccination. If we vaccinate the pregnant woman, usually this amount of antibodies increased. In a level, it may reach above the protective threshold, and it will be delivered in a good amount to the baby, which will protect the baby for a long period. The maternal immunization against pertussis is endorsed by a national and international organization. WHO, they advise for that, CDC and FIGO. So WHO, they advise to give the pertussis containing vaccine during the 3rd trimester between the age of 27 weeks and 36 weeks, or at least 2 weeks before the time of the delivery, which help to reach the maximum concentration of the antibodies in the maternal level and to deliver it to the baby. It shows that it is safe and highly effective, and it maybe have a high impact or in morbidity and mortality in the infant too young to have been vaccinated. It is most effective. As we can see here in the map, over 40 countries, they recommend pertussis containing a vaccine for a pregnant woman, and fortunately we are one of those countries, and we have it in the national national adult vaccination schedule, and this is give us now the force to try to let the women receive this vaccination, and we have to educate our women about that. So this is our national immunization schedule, and as you can see here, the Tdap is a part of the schedule, and they mentioned that it needs to be delivered between 27 and 36 weeks. But what is the challenging about that? We need to educate our physician. We need to educate the patient too, or the women in general. So OB/GYN physicians are often the primary clinician for the female of childbearing age, and they are in a good position to screen the immunization status and provide appropriate vaccination. In addition to the OB/GYN physician, of course, the family physician usually they have a direct contact with a woman, and usually they help us a lot to review the vaccine status for those women and advise them to receive the vaccine before they get pregnant too. However, the financial factor and the knowledge about the vaccine counseling, safety, and administration appear to be a barrier to the vaccine administration in OB/GYN office or in the clinic in general. The Infectious Disease Society of America and ACOG each published a general guideline for immunization of pregnant patients. The provider should be aware about immunization that are routinely recommended for all pregnant women: tetanus, diphtheria, pertussis vaccine, and influenza vaccine. Providers should be administered appropriate non-live vaccine to pregnant patients with a medical or exposure indication that put them in a high risk for the vaccine preventive disease. Following the delivery, the postpartum patient should receive all the recommended vaccine that could not be or were not admitted during the pregnancy, and this is what I mentioned previously. Providers should be aware of and following the contraindication and precautions for the immunization for the pregnant women. So, healthcare profession are that usually they have a high risk of implementing such vaccine during the pregnancy. They play a very big role to help the women or the pregnant woman to agree and receive the vaccine. Internet survey has been provided from women, more than 600 women. They filled the survey, and they were asked, and usually they were concentrating on if the patient has been offered about the vaccine, and in the other part, they were asking them about the vaccine itself, if they are aware about it. So in the first part, they found that 65% of those women has been offered the vaccine, and from those 65% of the women, 70% they receive the vaccine. In addition, 10% was recommended, but they did not offer them to receive the vaccine. From those, 37% they received the vaccine. And 23% of the women were not recommended or even offered to have the vaccine. 0.9% they received the vaccine. So the physician, they play very big role in orienting the patient and trying to help them to know about this vaccine and giving it to them. On the other hand, they were asking them about if they know that the Tdap vaccine it can be given during pregnancy. So 22% of those, they don't know that the Tdap was recommended. In addition, 18% they were concerning about the safety of the vaccine during pregnancy, and 15% was not recommended. They were not being recommended to receive the vaccine from the provider themselves. So, what are the measurements which help us to stabilize the maternal immunization in the general population and increase the acceptance and intake of this vaccine among our pregnant women? First of all, practice focused. So during the antenatal care or visit, we have to focus on the vaccine itself. It should be a part of the antenatal care. We have to educate and train our staff or our physician. We have to use a standard order for those who did not receive the vaccine, assign a vaccine champions, and reminder to the patient medical record, document and assess the vaccination status for all pregnant women. On the other hand, we have to focus on the patient too. We have to educate them about the vaccine by different way. We have a lot of way to educate our patient. By brochures, by social media. There is a lot of way to educate them. We have to offer them the vaccine during the clinic, and we have to explain for them more about the vaccine itself. We have to provide a strong and a direct recommendation of the vaccine itself. Thank you.
On behalf of ABOT, I would like to thank you very much for your kind delay.
Thank you so much, Dr. Reem, for this informative presentation. And you have highlighted the importance of the vaccines in between 27 and 36 weeks. and
today we have
the importance
prominent
of being responsible to deliver the
to
importance
know
of having
about
the
all of these
vaccines
details.
by all of us as
Actually,
a provider to the patients, so
Mahfouza
in
and
order to convince them.
Katie,
And now,
and
because we have a lot of
let me start
vaccine that
with
came up in
introducing
the
our
couple
chair
of weeks and a couple of
today,
years, we have
Mahfouza,
some kind of vaccine
pediatric
fatigue, and we
gastroenterology,
have vaccine
Saud
resistant.
Abdelaziz,
But again,
General
we
for
have
Health
to have a
Science
vaccine
Guard Hospital
recommendations,
in
which has
Jeddah.
to be highlighted
He's
by us. So thank you,
member
Dr.
of the
Areen, for
Saudi
this. And now we'll
for
move to the second speaker,
gastroenterology,
who is well
hematology,
known,
and
Dr. Mohammed Samanoudi.
nutrition.
He's a
Has
consultant in
over
internal
100
medicine
publications
and
in
infectious
pediatric
disease,
gastroenterology, and he is the
transplantation,
usual
infectious
speaker
disease,
in national
King
and
Fahd
international
Armed Forces
Congress.
Hospital in
With
Jeddah.
great pleasure, I would like
He's
to invite
a
Dr.
consultant in internal medicine,
Safti.
infectious disease, an assistant professor, Department of Medicine, Faculty of Medicine, Al-Qura University in Mecca. Has a fellowship in transplantation, infectious disease, and other fellowship in infectious disease from University of Texas, Anderson Cancer Center, Houston. He has a lot of contributions, in fact, a lot of posts, and he has been contributing very well in the scientific events and highlighting those topics that is related to infectious disease. So we would like to thank Dr. Mohammed for accepting the invitation today and being part of this event. And his topic that he's going to shed a light on is update on Tdap vaccination during pregnancy. So I would like to invite Dr. Mohammed. Please, the floor is yours.
Assalamu alaikum. Thank you very much for this kind invitation, and thank you GSK, Saudi Society of Family Medicine, and FIX for this great organization as usual. And I hope you have a good time with me today. So let's start. So our topic today is gonna be about update in the maternal immunization. In the beginning, this is my disclosure. So first, let's have some tips about the Tdap. So the Tdap vaccine is protect against tetanus, diphtheria, and pertussis. Usually tetanus and diphtheria are rare nowadays, and the pertussis case is starting to reach the level of concerns. And the infants are most vulnerable about the pertussis. So today we're going to talk more about the pertussis during the infancy period, and also here and there we'll talk about the tetanus and the diphtheria. So let's start with the tetanus. So tetanus is an infection caused by Clostridium tetani. It's a gram-positive bacilli. And usually how it happened, if there is any wound, and the wound contaminated with this bacteria, and the bacteria start to release the toxins, then the toxin goes to the central nervous system and start to do the following: acute onset of hypertonia, painful muscular contractions, usually in the muscle of the jaw and the neck, and caused like another name of the tetanus called lockjaw, and generalized muscle spasm. Prognosis is usually unfavorable, and even the treatment is a little bit difficult in those kind of patients, and the recovery is unfavorable as well. If we talked about diphtheria, diphtheria is a highly contagious respiratory infection caused by another gram-positive bacilli called Corynebacterium diphtheria, and usually cause a pseudomembranous pharyngitis. This is the most common cause. When you hear the word of pseudomembranous, you will face it only in two diseases: diphtheria, the first one; the second one is Clostridium difficile colitis, and we will see the pseudomembranous colitis. Bacteremia and cardiac involvement can occur, and this is usually, if it happens, it is associated with high mortality rate. So let's talk about our topic of concern today is the pertussis, or the whooping cough. It's also a highly contagious respiratory infection caused by Portadella pertussis, the gram-negative bacteria. The transmission of the pertussis usually occur through a direct face-to-face contact or contact to the infected respiratory secretions. It can cause a severe cough and usually characterized by a word of whooping cough. It affects all ages, but infants are at the higher risk of infection and also the complication. And we will see in the next few slides how they affect the babies and what are the complications. But here are some of the complications that they need to be hospitalized. Pneumonia can happen, and also seizure and death as well. So let's talk about the incidence of pertussis in infants. If you look in England, we see that the incidence is about 50 cases per 100,000. If you look at the USA, it's around also the same. But the majority of the cases, if you noticed, let's talk about the England. It happens, the majority of the cases below the age of 3 months, and this is the age that usually the infants did not receive the vaccination. They depend on the maternal immunization. And the USA and the Brazil, the New Zealand, they did it like in a 1 year. And also it counts the highest number because it contains those 3 months that the infants did not receive the vaccination at this time. So if you notice, the incidence of the pertussis mainly focused in below the 3 months or in the first year. And we will see in the next few slides why this has happened. So let's talk about the burden of the pertussis, like what the pertussis will do to our infants. So 50%, this is a study was published in the USA, and the CDC was taking that and spread it to the population. So about 50% of the pertussis cases in infants in less than 1 year, they need hospitalization. And the hospitalization rate are the highest in less than 3 months, followed by those in 3 to 6. Complication can happen, apnea in a 61%, pneumonia 23%, seizure around 1%, and encephalopathy in 0.3. Look at that, 1 in 100 cases they may die. So it's very significant to our infants, and it's concerning as well. If we talk about the maternal immunization in Spain, we have a case control study, and was done in Valencia, and they were like having a pertussis cases and uninfected control cases. Look at the pertussis cases were 22, and the majority of them were unvaccinated. About 77% were unvaccinated. And look on the opposite side, for the uninfected patients, 62% they were vaccinated, and at that time they measured the vaccine effectiveness to protect the infants below the 3 months is about 91%. So let's move to Australia. Australia, they were like doing also a case control study with a number of cases of 117 and the control also of 117, and they were measuring the vaccine effectiveness against the disease, and it was 69% in less than 3 months, and in less than 6 months they were like 39, and the effectiveness, and this was the main or the strongest point, that the vaccine effectiveness against hospitalization, it was about 94%. The reason behind why the vaccine effectiveness in less than 6 months was a little bit low, because in Australia, they were also considered the mild cases of pertussis. They were able to detect the milder cases of pertussis and count them in their study. However, the other countries, they were not. They were just including the severe or the significant pertussis cases. Here, if we look at the systematic review between 11 articles of pertussis, and they were measuring the vaccine effectiveness against the disease and against the hospitalization. If you look at the bars, majority of them against the disease were in 90s, but against the hospitalization, they were variable between the 50s and 90%. So overall, the vaccine was very effective against the disease and also against the hospitalization in many countries. So let's see about the impact of maternal Tdap vaccination in Brazil. So if you look at the time of the Tdap introduced there in 2013, look at the incidence. The incidence of the pertussis was like high, and once we introduced the vaccine, we see the nice trending down of the incidence by 55%, which was also a great result from the Brazil folks. Let's look at the impact of the maternal Tdap in Mexico. See, there was like a very high spike, and once we introduced the vaccine in 2013, that spike was to trend down. But in between 2016 and 2017, another spike happened, and that was because at that time there was a shortage in the maternal, in the Tdap vaccine in general, and many pregnant women did not receive the vaccine, and that's why we are attributing the increase of incidence in infants in Mexico. And at that time, it was because of the vaccine shortage. And this is also another like a strong point supporting the vaccine. And once we have a shortage, now the cases start to reoccur again. So let's talk about the Tdap safety, the Tdap vaccine, the safety of it during pregnancy. So two large studies were published in USA, showed that the vaccine is safe in more than 53,000 patients, and no any risk happened during the pregnancy within the 20 days of vaccination, the 42 days of vaccination. Another cohort study was done in more than 1,000 pregnants and showed that the antepartum Tdap vaccination did not lead to any pregnancy-related morbidity or even a repetitive dosing in a serious pregnancies, and we'll talk about that, and we will stress about this point in the next few slides as well. In New Zealand also, the vaccine was safe to the pregnant women as well, and no major side effects were happened to the pregnant women. And in Argentina, the same thing, and also in Thailand. So let's talk about a little bit about the Tdap vaccination to the general population. So as we know, the pediatric age group start by the 2 months, and they will follow the MOH guidelines. But Tdap vaccine in each pregnancy between the 27 and 36. So the question here, why I think Dr. Reem talked about that, but I would like also to stress in another point. So in the third trimester, as we know, the level of antibody that goes to the baby during the delivery, this is the protective level to the baby in the first 3 months. But why we need to repeat it each pregnancy? Because many studies showed that the level of the Tdap antibodies in the pregnant women after the delivery, it goes down significantly in 1 year. And after 1 year, that level is not protective for the fetus. So that's why we need to boost it again and again and again in each pregnancy to reach to the level to protect our babies after the delivery. Tdap booster should be administered to the adolescents, preferably in age 11 to 12. And believe me, that this is the age of the highest activity level. A lot of times we get faced to those people. My son stepped on a nail while he's playing outside. What should we do? Is he vaccinated? I don't know. Did he take the vaccine? I remember he took the vaccine when he was during the school age. I don't know if he's like up to date or what. And here is the time that we need to review the case closely and see what is the risk factor for this patient to develop the tetanus specifically. Tdap and TD booster for adults every 10 years. Please, healthcare providers, please keep that. Every 10 years, make sure that you are taking your TD booster. Or if you didn't have the TD booster, take the Tdap booster. Because you don't know at what time you are going to get injured during your work in the hospital, while you are in OR or whatever, anything. So a lot of surprises is going to happen. And you will be safe and protected if you are getting your booster every 10 years. Our elderly people, their level of coordination after 65 put them at risk for fall, and their immune system is not that good because the immunosenescence that usually happen after the age of 50, and their immune system will go down, so they are at risk for not even the disease, the complications of the disease. What if the adults has incomplete history of unknown vaccine history of the Tdap? If never been vaccinated, they should receive a series of 3 vaccinations containing at least 1 dose of the Tdap, followed by a TD booster in 1 month, then a TD booster in 6 to 12 months. But if not fully immunized, 2 options here: either to receive 1 dose of the Tdap or to measure the antibody level. If less than 0.01, they should receive a 1 dose of Tdap. If more than 0.01, no need. At the end, I would like to stress on that table. I usually get asked about this table. Most of the time, like I can say monthly based, I get asked about this table. So that's why I would like to show it to you. What if like a wound happen, or like a person who stepped like on a dirty nail outside in the street? What's gonna happen? So if it's unknown vaccination status, or the person received less than 3 doses of the Tdap, if the wound is clear or minor, do they need to receive a Tdap again? Yes. And how about the tetanus immunoglobulin? Tetanus immunoglobulin, no need. But how about if other wound like dirty or contaminated, if unknown, they need to receive the Tdap, and also they need to receive the tetanus immunoglobulin. And this is the only time that we need to give our patient the tetanus immunoglobulin if their vaccination less than 3 doses and the wound is not minor or not clean or contaminated. But look at that. What if the patient received at least 3 or more? So no, if minor or clean, no need to receive the Tdap, except if last time he received the TD booster was more than 10 years. So that's why I'm saying, please try to keep your TD booster or Tdap every 10 years. And how about all the other wound? If happened and he received more than 3 doses, so they said no need to get the vaccination if more than 5 years of the Tdap vaccine was given, and this is only for the dirty or contaminated wounds. And this is how we usually deal with our patient in ER, in family medicine clinics and internal medicine clinics. They come all the time after they have this wounds, and they were asking about what to do in such situation. It was a little bit away from the maternal immunization, but I felt it's important to mention it, as this is part of the benefits of the Tdap, not only for the pregnant women, but for the all population, including the healthcare providers. Thank you very much.
Okay, thank you so much, Dr. Mohammed, for this illustrative, elegant presentation. And it's the time now to have the surprise of having one of our residents in IMC Family Medicine program presenting a very interesting topic, which is the counseling pregnant lady for vaccination. And I think this is very important topic. Why? Because we encounter this kind of hesitancy from time to time, not only with the general population, but with a special focus for pregnant ladies. Dr. Amira Ilahi, she is a resident family medicine in IMC, Jeddah. She graduated with a bachelor degree in medicine from Ibn Sina National College in 2018, and now she's a family medicine resident. Throughout the years, she demonstrated a high competency and dedicated for upgrading herself and flourishing and enriching all the people around her with her inspiration to learn more and more and to be a competent family physician. So we can see the real family physician in her, and that's why we give her the privilege of being with us here today. So Dr. Amira, please, we would like to welcome you here to tell us about the counseling pregnant lady for vaccination. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm too short for this. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I would like to start off with thanking the audience both virtually and physically. I would like to also take the opportunity to thank the JSK company and the FX organizing group for this effort. And finally, Dr. Ashraf Amir for this beautiful invite. Thank you very much. And the speakers, Dr. Reem and Dr. Muhammad. I really enjoyed this informative lecture. So I'm going to take you guys to a brief journey into counseling a pregnant woman onto taking the Tdap vaccination. These are my disclosure statements. Okay, so we have a brief case. We have a 34-year-old pregnant lady at 23 weeks gestation, gravid 2, para 1 plus 0. She came to the Women's Health Clinic inquiring about the need to take the Tdap vaccination for her current pregnancy. How to approach such a patient? Like we all know, we all start with proper history techniques to build quality rapport with a patient. So we start off with demographic data, gravity parity history, LMPs, gestational age, expected date delivery, any OBGYN history, in brief medical history, any allergies, drug histories, and past surgical histories. The first status or stage of counseling any patient is exploring. So we start with open-ended questions like any ideas, concerns, or expectations the pregnant lady might be coming with. So in the case, our pregnant lady's concern is the need to take the Tdap vaccination in her current pregnancy. So a repeat of it. So we're going to start off by explaining that the amount of antibodies in a female's body is highest about 2 weeks after getting the vaccine. And like Dr. Muhammad mentioned earlier, it remains until that year ahead. So she needs a repeat of that in order to secure that her baby gets the greatest number of protective antibodies and the best protection among the diseases. So we can also recommend with a strong statement, which is the CDC, and we can mention it to her, that the CDC recommends that all women receive the Tdap during the periods of 27 to 36 weeks of each pregnancy, preferably during the earlier part of this time period. The second stage that we can go around and talk with the patient is the understanding step. So what is the Tdap vaccination? The Tdap vaccination is the contents of the Tdap vaccination includes tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis, which is a vaccine that protects against 3 main serious diseases. So when a patient understands why we're giving her the vaccine, what are we protecting her from, and most importantly, collaborating that with protection for her child, since she's a welcoming mother to that child, would even support more the taking of the vaccine itself. So what are we trying to prevent? Again, Dr. Muhammad did an amazing job. I can never compete with that in explaining what each and every disease is. But in brief, the rising star is the protection against whooping cough, which is pertussis. It's a highly contagious disease. Through a respiratory tract, it affects a respiratory tract infection and causes severe coughing, paroxysmal coughs, and leads to coughing, and leads to vomiting, excuse me. The reason why it's on a rise, as mentioned, Dr. Muhammad mentioned as well, is that the vaccination status has been on a up and down roller coaster status. The other thing is that the whooping cough can be mistaken for a common cold. It says it's a whooping cough, but sometimes the patient comes without the cough itself. The second disease is tetanus. It's not spread through person in person, but through a cut wound, and leads to fatal and low prognostic ends. The last disease is diphtheria, which causes a thick membrane-like covering, the pseudomembranous pharyngitis, which is very painful for the child and decreases the oral intake of the child, which leads to even further complication. So if the mother understands what we're trying to protect the child from, it's also going to help with the compliance of taking the Tdap vaccination. So again, what is the importance of taking the vaccine? After a woman receives the Tdap vaccine, her body creates these protective antibodies, especially through the earlier third trimester, with a higher concentration of immunoglobulin reaching the fetus, and protecting the child throughout the vulnerable period, which is between the birth and up to the ages of 2 months. Why is that? It's because the Ministry of Health's national immunization schedule starts giving the immunization at the age of 2 months. So you have a window period of since birth up until 2 months where the child is vulnerable. So getting the Tdap vaccinations between the 27th and 36 weeks of pregnancy, according to the CDC, lowers the risk of whooping cough in babies younger than 2 months by around 78%. A quick stats, like Dr. Mohammed also mentioned, is any child less than the age of 1 year with pertussis disease in the USA, 50% were seen to require hospital treatment. We can also mention that to the mother and involve her in statistics, so it can even magnify the amplitude of getting such a disease. So the mother might be coming and asking, is the Tdap vaccination safe? Yes. Tdap vaccination is completely safe, and as Dr. Ree mentioned, it's a killed vaccine. The most common side effects that she might be facing would be mild redness swelling around the injection site, and sometimes headaches, fevers, and chills like any other vaccines that will wear out in a few or coming days. The vaccine does not contain any live bacteria. So what are the contraindications of taking the Tdap vaccine? Not only do we just beautify the vaccine in the mother's eye, but also in order to gain her confidence, we have to also mention a few of the contraindications of taking Tdap, like any other procedure that we're going to do. We have to take a consent, we have to explain to the mother thoroughly what she should be expecting. So one of the two major contraindications of taking the Tdap vaccinations would be severe allergic reaction, anaphylaxis, after a previous dose of any tetanus toxoid, diphtheria toxoid, or pertussis antigen-containing vaccine, or to any component of the vaccine itself. The second contraindication would be the appearance of encephalopathy within 7 days of administration of a previous pertussis antigen-containing vaccine. There are some points to keep in mind in order to also further involve the mother into our counseling and to fully put the picture around and the complete advice as well, is that the Tdap vaccine should be administered immediately postpartum, like Dr. Ree mentioned, in any woman who has not previously received it or has last received it for more than 10 years earlier. So if a mother during her current pregnancy did not receive the Tdap vaccine, she still has the chance to take it after or during the postpartum period. The other point to keep in mind is that if you have a family member who will be in close contact with your baby and they have not been vaccinated with the Tdap vaccine, they should also get a single dose of Tdap vaccination. The American College of OBGYN released a statement in 2016. They used the term cocoon, which means any person cocooning or surrounding the infant without vaccinations should receive a dose of Tdap vaccination. And they should be receiving it at least 2 weeks before the close contact with the infant or the baby. The reasons to vaccinate a pregnant woman earlier than 27 weeks, there are certain criteria in which we can give the vaccine before the period which was between 27 and 36 weeks, and that is which includes unknown or incomplete vaccination history, pertussis outbreak. She went to a kindergarten with her younger child and there's a pertussis outbreak, she is more likely to get it. So she is one of, she's a candidate of getting it earlier than 27 weeks. Another thing would be inconsistent prenatal care follow-ups or as a part of routine wound care management. So before, let's say we have a woman who's pregnant, she went to a cut wound and she went to an ER, and the ER physician calls you and asks your opinion as to when to get the Tdap vaccination. Do we stick to the 27 to the 36 week period? No, we can still take it earlier, but she doesn't have to repeat it again, okay? So if a pregnant woman is vaccinated early in the pregnancy, before 27 to 36 weeks of gestation, she does not need to be vaccinated again during the specified period. So there are some precautions that we should discuss together. They include that the syringes of the Boostrex or the other company of the vaccine contains natural latex. So if she has an allergic reaction to it, we should also keep that in mind. The decision to give Boostrex should be based on benefits and risks if a patient was to have had Guillain-Barré syndrome occurring within 6 weeks of prior tetanus toxoid containing vaccine. Any progressive or unstable neurological conditions that we should know of are reasons to defer the vaccination to a later on period. Another thing would be people who have experienced arthus-type hypersensitivity reaction, which is another type of bacteria that has a different kind of vaccine. Following a prior dose of tetanus toxoid containing vaccine should not receive the Boostrex unless 10 years have elapsed since the last dose of the tetanus toxoid containing vaccine. Syncope is something that's associated with any administration of any injectable vaccines, and it's absolutely normal as long as the place is secure, and we ask her if she has the tendency of fainting, which most women tend to have. So we have to also address some of the myths that may concern the patient. She might be coming, and most of the questions that women come with are, can the whooping cough be contracted to adults? Like Dr. Mohammed mentioned, it can, but the children, they're more vulnerable, again, like Dr. Reem mentioned. So does the Tdap vaccine provide lifetime immunity? No, that's why it needs booster doses accordingly. Can whooping cough be contagious without cough? Yes, and this is an important point. Does the vaccine cause pregnancy complications or birth defects, which is one of the main concerns, as Dr. Reem might know in her clinic? They're always afraid that their baby gets any congenital or birth defects or any pregnancy complications per se. We should secure it and tell them that there is no evidence of adverse fetal effects from vaccinating pregnant women with an inactivated virus or bacterial vaccines or toxoids. Does the vaccine cause autism? As we're in a trend of the autism era, many people still have that thought that vaccines would cause autism, especially with the MMR vaccines. But I've had people coming to the clinic asking, would my son get autism? Because now they're having the awareness of that spectrum. There is no evidence existing that suggests that any vaccine is associated with an increased risk of autism or adverse effects due to exposure to traces of mercury-containing preservative called the thimerosal. So we can explain that to her, that there's a certain mercury-containing chemical called thimerosal, but the Tdap vaccinations, thankfully, does not have that content or chemical. So, coming to the stages of action, how is it taken? We explained to her it's a single dose vial, 0.5 ml intramuscular, and it's all good. Summarizing the benefits, it prevents not only the severity of infection to the infant, but to the mother herself. And again, to the infant through passive protection against vaccine-preventable infections acquired independently after birth, during that vulnerable winter period we mentioned earlier. So again, the risk of infections, we have to explain that we have different types of vaccinations. We have the live attenuated, there's a theoretical risk on fetuses, so it's contraindicated in pregnancy, whereas the inactive viral or bacterial vaccine has no risk to fetuses. So it's also a good opportunity to also shed the light on the influenza vaccine that's also given during the pregnancy. So, if the patient comes to you and she's still hesitant to take the Tdap vaccinations, what can we do? How can a physician overcome the vaccine hesitancy? And what is the vaccine hesitancy? So a vaccine hesitancy is a term that came out quite recently, meaning that the vaccine is available, but the patient is either hesitant to take it or reluctant to take it or refusal to take it in the first place. We can overcome it as physicians in something called the 3C model. I'm not going to go into details, but just to keep it in mind, in brief, what it tells us is that if a patient has confidence in her physician, builds a good rapport with her physician, and the physician himself has confidence in the knowledge he's giving, it's going to help trespass that vaccine hesitancy. And obviously, having it conveniently available in your center. So one of a few points I would like to mention is that whenever there's a patient-centered, tailored, private conversation about the benefits of Tdap for babies, combined with the easy access of the vaccine, can help broaden the coverage of the vaccine itself. The other thing would be to strongly recommend the Tdap vaccine to pregnant patients and incorporate Tdap vaccination into our routine care. One way of doing it is to, even if the patient does not accept your recommendation initially, we cannot force it into her, of course, but we continue to offer it with subsequent visits in her antenatal care. The other point would be is that to also, a good idea would be to concomitantly administer the inactivated vaccines altogether. Like I mentioned earlier, the Tdap and the influenza. It's safe and it may also optimize effectiveness of immunization efforts. Another way would be is to emphasize again and again the need to be vaccinated during every pregnancy to protect each born because of the variation of the immunoglobulin by the end of the year, like Dr. Mohammed mentioned. To reassure to the patients the extensive evidence showing that Tdap is safe for them and for their pregnancies. To highlight stories of your patients' positive experiences with Tdap is also a very good point. So patients like positive energy. We all like to have positive energy once and like in a lifetime. At least when you come in and you share a good story with the patient, it's always a good boost of confidence to go ahead and take the vaccine as well. And they feel confident to take it. For women who are Rh negative, another strategy worth consideration is to administer the Tdap vaccination during the same visit as the Rhd immunoglobulin administration. There is no contraindication to that as well. Another point would be to link the Tdap vaccination to the screening for GDM. So we have a period of time where we screen pregnant women for gestational diabetes mellitus. At that time, we can also offer the Tdap vaccination simultaneously. The CDC, the Center for Disease Control and Prevention, shared a mnemonic, which is called Share Mnemonic. They have certain points as to help guide physicians on to how to talk the pregnant women to take the Tdap vaccination. They include sharing specific reasons, just to recap, why the Tdap vaccination is right for pregnant women during every pregnancy, highlight positive experiences on your personal experiences in your practice to reinforce the benefits of Tdap vaccination, address your patient's questions and concerns. Like we started off with the case, we always start off addressing why are you concerned? What are your ideas? What are your expectations? Make the patient feel like she's involved. Remind your patient that vaccines protect not only her, but her family from many other serious diseases, and explain the diseases that we're trying to protect her from. Explain the potential costs of getting pertussis, especially for infants, since the pertussis is on a trend. These are my references, and thank you very much.
Thank you so much, Dr. Amira, for highlighting the counseling for a pregnant lady for the vaccine, Tdap. And I would like to ask and invite the speakers to be on the stage here for the Q&A session. Dr. Arim, Dr. Muhammad, Dr. Amira, come back. Still, we have some questions. We received it from our audience through the online. But again, I will just give the privilege for our physically attended to give questions if they have. Any questions from the audience here? Questions? No? Okay. I have a couple of questions, Dr. Muhammad, Dr. Arim. What if the pregnant lady missed the Tdap? I think it has been mentioned, but it has been asked again, you know, just to highlight it again, just to reinforce the concept.
Okay, so if the patient did not receive the Tdap during the pregnancy, she can receive it immediately after delivery.
Yeah.
And she, like one dose is enough for them.
Okay. Dr. Muhammad, why acellular pertussis? Why acellular? Why not the regular pertussis? Why they have removed the cellular part of it? If there is any rationale behind it?
So there is no rationale behind it. So that's just like the acellular, when they compare it to the cellular part, they found that the acellular is most reactive to boost our immune system and form more immunoglobulin against the disease.
Okay. Do we get any cases of diphtheria and pertussis? Do we come across these kind of infectious disease currently?
So I have a case of pertussis now in the hospital.
Okay.
But diphtheria, never seen. Yani, thanks God, up to now. And tetanus, yes, we saw a couple of cases of tetanus, but I want to strengthen also on the point of the prophylaxis and the importance of the vaccine that prevent a lot of cases of tetanus.
Okay. Do we have any active surveillance, for these kind of infectious disease?
Yes, of course. And usually the Department of Preventive Medicine and Infection Control, they are like strongly involved in such cases with following them up and making sure that they are safe the whole duration.
Okay. Dr. Amira, you have illustrated elegantly the counseling for a patient, but the scenario comes here. If she totally refused, what will be your action?
Well, I would like to start off with something you taught me, Dr. Ashraf, is that you never force into someone, but you can always try to talk her into it, explain again and again. Another strategy would be, like I mentioned, frequent visits. So we don't have to all squeeze it in one visit. We can, again, explain it into bunches until she comes into a conclusion that's good for her and her baby. That's one way of putting it.
Okay, thank you. But in fact, there is another modalities that has to be kept in mind for those who are refusing totally. After exhausting all the efforts to convince them, you have to hold them responsible for their decision. So you go for 3 different actions. First, you elaborate that they are at risk of having and contracting the disease for themselves and for their babies. And the immunity, which is supposed to be for the first 3 months of their baby, will be totally not existing. So they are going to subject their infants even after the childbirth to the infection. The other things to tell her that if you develop any signs that highlight this kind of infections, like you have a cough, fever, rashes, you have to go to the hospitals immediately. The third thing is to say that you have to tell your doctors whenever you encounter them that you did not take the vaccine. So by these 3 modalities, you are holding her responsible for her action, and she will feel she is so frightened, and she is exposing herself to the danger, and ultimately she might think about getting the vaccine later on. Okay. The question is, I think it has been highlighted also, why the Tdap given in the late trimester of pregnancy from 27 to 36 weeks? Why not earlier? And you have said if she misses, she can take it later on. Anyone?
Yes, so we've been talking about that. Like in the 3rd trimester, the antibody level or the Ig immunoglobulin level will reach to the protective point or to the protective level to our babies, specifically at the time of the delivery, will make them protected until the age of 2 months or 3 months. It depends on the national immunization schedule, and protected from getting those pertussis mainly and diphtheria and tetanus. And as I mentioned before, in each pregnancy, because that level is going to drop down and to the unprotected level for the baby. So that's we need to boost it every year.
Yeah.
And every pregnancy, sorry.
The transmissions of the maternal antibodies go through the placenta. But how about the antibodies which is available in the colostrum, the first part of the milk? Does it contain any antibodies against against the tetanus, diphtheria, and pertussis? Or it just confined to the placenta transmission to the baby? So
majority of the antibodies, it goes from during the delivery, but also the breast milk, it contains the antibodies. But I will let Dr. Reem, if she wants to add anything about it.
I'm not really sure about it, but what I know, I don't think so, but I'm not sure about it.
Yeah, one of the advice that we usually give to the mother to have a breast feeding for her baby, just to give a full protection from 3 to 6 months in the early stage of the infancy. Definitely, there is some kind of antibodies.
There is an immunoglobulin usually in the breast milk that protects the baby from the gastroenteritis, respiratory symptoms. But regarding the petrosis itself, it's like, this is what I'm saying, I'm not pretty sure about it.
Okay.
I have a
طيب,
question.
any questions from the
Yes.
audience here? Do we
Yes.
have any? Yes, I
Assalamu
think.
alaikum.
Okay. You're first.
yeah.
Please go ahead.
I have a question for the pregnant lady. If she get it in the first pregnancy and in the second pregnancy after 2 years, will she benefit from the vaccine she received it in the first pregnancy, or she has to take it every pregnancy?
So as Dr. Muhammad mentioned too, that the level of the immunity, it will drop down after the delivery, and it will reach to the lower level at the end of the year. So if the patient got pregnant after 1 year, she needs to receive the vaccine again.
Okay.
Okay, we have a question here for Dr. Muhammad.
Since I'm outsider today to get to those kind of the vaccination, my question regarding the special cases like a hemophilic patient or sickle cell patient, is there any precaution to give or not to give?
No.
Yes, Dr.
The patients with asplenia, or they have had a splenectomy, they are very important to give them the pneumococcal vaccine, which is very important because they are at risk of having pneumonia. But I'm not very sure about the Tdap.
So, as Dr. Ashraf said, the most important one, the encapsulated organisms, which are the Streptococcal pneumoniae and the Neisseria and the Capnocytophaga and the Haemophilus influenza. So those are the vaccines that they need because the aggressiveness, and they depend mainly on the humoral immunization, and in those people it's gone. So even if they have their spleen, the infection is tough. But what if they don't have the spleen? Then the complication is gonna occur, like definitely for those people. So they need they need the vaccination for the encapsulated organism more than the other organism like Tdap. But also, of course, they will benefit from the Tdap as well. But to stress on them, the Tdap is gonna like the general population, but the most important one, the encapsulated organisms.
Okay, any other questions? Yes, we have one question over here. Mike, please.
So my question is the protection coverage, does it apply to twins if the mother had twins or multiple, like gestations?
Yeah, actually, the maternal immunity will develop in a very high level that can cover whatever number of the pregnancy she's having.
Okay, thank you.
Okay, any other question? So I think we are coming to the end of our session. I just want to deliver the take-home message that the Tdap should be delivered from 27 to 36 weeks for all pregnant ladies in each pregnancy, and make sure that you hold this kind of responsibility as a healthcare provider to capture this opportunity and to enhance the antenatal care counseling by convincing our pregnant ladies to have not only the Tdap, but also all the recommended vaccinations in our national immunization program. So with this, I would like to thank our guest speaker, Dr. Muhammad, Dr. Areem, and Dr. Amira for the wonderful contributions for the success and enriching our scientific gathering with a lot of information regarding vaccinations, with a special focus on the Tdap. I would like to extend our thanks to the Saudi Society for Family and Community Medicine, who has been taking the objective of getting us, all of us together, to get into this kind of academic activities to enhance our knowledge and to sharpen our expertise in the very important field which represent the preventive medicine. And I would like to also give my thanks, a special thanks to GSK Company for sponsoring this event and make this wonderful gathering viable. Another thanks goes to Fexus Company for organizing this event. So please do your effort, spend a lot of time with your patients, take the responsibility along with you to make sure that we are putting our pregnant ladies in saving God, not only them, but also their fetus and their babies in the future. With this, I would like to thank you, all of you, to attending our sessions. Looking forward to have you again and again. And remember that we have a lot of activities almost every 2 weeks. We have one of the activities that cover different spectrum of medical entities, regardless of specialties. And this is a beautiful part of being a family physician. So this is a call for all the junior staff to have this kind of wonderful specialty. With this, I wish you a very wonderful night, and we will have the dinner together, inshallah, next door. Thank you. See you again. Bye-bye. you.